Hey Dan, just if you got a chance, give me a sign in the chat that you can hear me okay, or feel free to jump on the call too. If you ever want to introduce yourself, or if you have a question or anything like that, you'll probably have to unmute your screen before you start talking, but that should allow you to jump in on the conversation. Okay. We'll wait a little bit longer to see if we get anybody else on today's call, but topic we're going to be talking a little bit about today is tendinopathies. So if you got any specific cases or any type of clients you're thinking of currently or any questions, feel free to let us know. But we're going to dive a little bit deeper into the subject this time. Got it, Dan. Thanks. Yeah, we're looking to get as much of this as we can going on. And just for everybody's reference to, you're probably seeing a lot of emails. Oh no, you're fine with it. It's muted right now, so I can't hear anything in the background. If you want to jump in, feel free to unmute it. If you got a question, just type it in the chat. That works too. But we're all good with that. Yeah. So with Sports Rehab Expert, there's a lot of emails you're probably getting out currently right now. There's probably some changes you've noticed if you followed the site for a long period of time. There's some changes in the format of how the site looks, how it feels, just how it's operating. We're looking to add a lot more one-on-one communication connection with the members, as well as everybody on the email list too. So we have the members area completely redone in the way we're looking to have it, and just kind of continually progressing it. So the big part that you're going to see now is these weekly calls, and the purpose of it is for you to just jump on during lunch hours. If you have questions ahead of time and you can't make it, just submit a question. That way we can get to answering some of these things too, and just meet you where you're at, where you're struggling, and help everybody out. And like we said in the past too, we may not always have an answer immediately, and we'll give you the best answer that we can in the moment. But it'll also give us something to kind of look into a little bit deeper if we need a bigger understanding to help give you a better answer too. So with all the emails coming out, just kind of bear with it for a little bit right now. We're going to just start highlighting some different things, get some of the free information out just to re-engage some people. But the idea is to get everybody on these calls here, coaching calls moving forward, and just get more interaction with people. Something else on the back end that we're working on too is developing some live courses, as well as online courses. And so these courses will dive a little bit deeper into all the different subjects, our treatment philosophies. Hey, Zavrinis, nice seeing you, man. It will dive a little bit deeper into some of the concepts and how we think about things. And then again, further, the idea of having this too is when you go to a course, sometimes it brings up more questions than it does answers. And that way it's something where you can immediately go back and start asking for feedback, suggestions with clients and patients that you may be having. So that's what we're looking to get into more. Today we're going to be talking about tendinopathies, so we'll get into that. We kind of left off a little bit of a cliffhanger last time, but the big thing I want to start talking about with tendinopathies, a lot of tendinopathy research that you read upon is a lot on Achilles or patellar tendons. I'd say that's where the majority of the injury site's location is, just in the various different research articles that you're finding. But we need to kind of figure out how to best apply this to all different type of tendinopathy situations that are out there too. So when we look at the tendinopathy, one of the things that's crossing my mind is always, what are the different muscle contractions that I can utilize for my clients? So we all know there's eccentric, isometric, concentric types of contractions. And just depending on where someone is, depending on the stage of tendinopathy that they're in, utilizing these certain types of contractions may be more advantageous than others. But at some point in time, you always want to get to utilizing all these types of contractions, because in life, sport, different things of that nature, you're going to utilize, and you have to utilize all these different muscle contractions. So that's in Eric, or Eric and Daniel, do you guys have any familiarity with triphasic training by Cal Dietz?
Yeah, I read the book. A friend recommended it, and yeah, I read the book. I can't say as I remember a lot. That was like 4 years ago.
Okay. Yeah. So I like his concept. And his applies more to sports performance, where he's setting aside different training blocks for eccentrics, isometrics, and then concentrics, and kind of working on those specific muscle contractions. And yeah, Dan, it's definitely a good book too if you're interested in more. It's more a sports performance realm, but we're going to talk a little bit how it kind of applies to rehab as well here too. So he gets into just different training blocks and how you can utilize the different contractions for sport performance aspect of things. And the idea is if you kind of there's like a V continuum here where it's coming down, and you got your eccentric to isometric and then amortization phases and the concentric. And the shorter you can manipulate that time frame, or the quicker that it can happen, the more likely someone's gonna be able to change directions, jump higher, things like that. The longer that change happens, so the wider that V from eccentric to concentric, just the bigger time frame that it happens, probably the less explosive the athlete's going to be. That's a very general approach to what he's talking about, but just to give you a little bit of a background there. So same kind of thing with tendinopathy. And Eric, I'll let you get into the stages in a little bit here, but so the first couple things that we're thinking about, and we know from Jill Cook and a lot of the other people who've done research out there, is that isometrics is obviously an easy place to start. And it also has an effect for pain analgesics as well too. So it's an obvious place to start, but if we can somehow manipulate an exercise to get someone performing an eccentric at the certain point in time, because people are stronger with eccentrics than they are concentrically too. So if we can do some type of eccentric activity, a lot of times, depending on how we perform the exercise, it's another easy way to kind of start the loading. So isometrics and eccentrics are kind of the always place where I'm first starting, and then starting to think about how do we tie in concentric contractions after that as well too. You got anything to add to that there, Eric?
Sorry, I was just reading his question.
Yeah.
Yeah, I want to say yes. I believe so. To Dan, Greg, to your question. Actually, I forget. I was reading his question.
Yeah. Sorry. Just going into some of the different stages and talking about utilization of certain contractions at the different stages. So you got the disrepair, reactive, and degenerative tendons.
Yeah, so if you look at the big, and it'll always be talked about, the three phases. You have reactive, which is when you're in your most reactive state. That tendon is irritated, pissed off, if you want to say it. Usually I'll actually tell people that. They seem to understand that. And that's where you need to be a little bit more cautious with your loading. And then you have disrepair, where it's going towards degeneration. You may see some of the early phases of what's going towards degeneration, which is the hole, if you've heard of it, like the donut or the hole, as far as your tendon is normally kind of one uniform unit, and then it gets to where it has little degenerations in it, so small holes. That is after several months. It goes from reactive, disrepair, degenerative. Obviously, the sooner that you can get to them, the quicker you can make a change as far as reducing activity. But depending on how long they've had it, which stage they're in, then determines what your course of action will be. Regarding isometrics, if they're in a reactive state, you need to introduce loading, so you may go more gentle. And then if you look at isometrics as it goes forward, disrepair, and then towards degenerative, you need to be putting them through, and we'll talk about this more, but as far as isometrics, they are huge, because you can utilize isometrics, have them get up to 4 out of 10 pain, and you can be sure that you're making potential change in that tendon, and then you're trying to essentially reverse what was done. It's in question if you can actually reverse it or not. But so that was a long way to say, depending on what stage they're in, is I guess how you would utilize your isometrics.
Yeah.
And oftentimes eccentrics are going to be way too painful. Eccentrics usually suck even if you don't have tendon pain.
Yeah. And that's where isometrics become helpful, because it's just the easiest point of entry to start loading someone. So as far as when to start implementing this stuff, Dan, with someone who is immediate acute injury, there should be some type of way that you can still load them isometrically. And with the isometrics, it doesn't necessarily have to be 100% contraction. It could be, something easy as 50 or to their tolerance as far as how they feel. And same thing with eccentrics. Eventually, when you get to them, go by what they're telling you. So if there's some discomfort there, just try to distinguish between how intense that is. If it's sharp shooting, burning type sensations, it's probably being a little bit too aggressive. If it just feels like a muscle work and a mild to moderate increase in their symptoms, so it's kind of yellow lightish, if we use like a red light, green light, yellow light analogy, that's okay, is so long as soon as you stop, it goes right back to where their baseline level of pain is, wherever they're at from their acute standpoint. So that's the biggest thing, is when they stop the activity, it should cease or go back to their baseline level immediately. And that holds true for any exercise that you utilize across the whole continuum there. With the isometrics, you should be able to start some type of loading initially isometrically in whatever range of motion that they're most comfortable in. So you may not utilize all different, so that's where like angular isometrics come into play, where you choose an angle where it's maybe not as provocative, and you just start there and start the loading process there, and then start working through some other angles too. And then as you start going through more of those angles and they're not as painful with those various different angles, then it's probably a good time to start introducing some of the eccentrics, because if they're hitting multiple ranges of motion with isometrics, they probably can start doing an eccentric, keeping that same yellow-green light analogy in mind.
To tangent off of your yellow, red, yellow, green, Dan, I would say with this situation, I listen to my patients almost more than anything. Whether they're in reactive, disrepair, degenerative, I would pay attention more to what their pain levels are than anything. You have to, ideally, you need to get them to loading. So if they're 2 weeks out and they just strained their rotator cuff, but they can handle 100% external rotation isometrics against the wall and they're hammering it, and they say there's 1 out of 10 pain, I will have them hammer it. Even if you think maybe, is that good on the tendon? Is it not? If they can tolerate it, usually with these tendon issues, pain is a really good indicator of if something is going wrong. And if they're tolerating that okay. Same thing if they've had it for 6 months and you start it. I just listen to your patient a lot with this one. Usually for isometrics, I do a ton.
Yeah. The other thing too is don't always focus on what they can't do. Start finding things that they can do and work with that. And then oftentimes as you start working with things that they can do, now you start noticing they're able to start doing more and more things, and now you have a broader scope of what they are able to do, and there's a bigger menu to choose from after that too.
Yeah, with some of the hypersensitive patients, oftentimes they're super sensitive. Even let's take somebody who would be very sensitive, post-ACL repair. They are not going to appreciate any kind of movement. So strength through movement, which would be your concentric, eccentric, it threatens them personally because they just had their joint or their ACL worked on. It also threatens them as far as their system. So isometrics with no movement happening, usually the brain is more okay with that. It says, okay, there's no movement in the joint. This isn't a bad thing. It's just a little bit of muscle contraction. So yeah, some of your hypersensitive patients that they're just terrified you're going to even move them, isometrics work pretty decent with those. But again, you always have to take into consideration if people are pretty irritated.
Yeah. Let's start going into some more examples then. Dan, if you got other examples you want to get to, feel free to let us know. So the patellar tendon example, so taking the isometrics into equation, Usually the isometrics are a little bit harder to do in closed chain. So in open chain, isometric knee extension is going to be something useful to start there. So I know a lot of people kind of have a negative connotation towards like the knee extension machine, but it's very useful to utilize for isometrics. You can get creative, such as using a wall or just kind of pushing out into a band and holding it there too. You can kind of get creative with those different things, but that's an easy way to kind of start with the isometric loading. Yeah, using open chain for isometrics. Initially, that's probably the simplest, especially if you have someone who has like motor coordination. You know, they're not the most coordinated person in the world. Your athletes, you probably can get away with some closed chain stuff, but someone just general population who is not as much coordination, open chain is easiest place to start. So again, working different angles, you can start at 90 degrees, you can start at 45 degrees, kind of wherever they're most comfortable, and start ramping up your intensity of that isometric there. And then other things you could do is if you wanted to try to get away with some type of closed chain variation, is some type of supported bilateral activity. So that could be, you know, hands held, squat. They're using a parallel bar to kind of squat down to a certain depth and just making sure their form looks good, and just holding at a particular range of motion that is again not provocative for them. It's a comfortable way to start loading, and then when they stop, nothing lingers on after that too. You got any examples there with that?
Yeah, I'm gonna give a pretty specific example. I work with a lot of overhead athletes. What's an extremely provocative position for your overhead athletes? It's where they need to be. 90 degrees abduction, 90 degrees external rotation. If they do not want to get there, this is just going to be one use, and I'll show another. If they do not want to get into that position because of pain, you could hypothetically have them laying supine on a table. I utilize a lot of manual resisted isometrics. I like to be able to feel them contracting. I don't know. I just like to give good feedback cues. It gives me an idea instead of them just using the external load. So I will take them, maybe you bring them at 90 degrees abduction and you bring them to 30 degrees external rotation. Have them do a few external rotation isometric holds, and then see if you can bring them back to 45. See how they do. See if you can bring them back to 60. It's almost a way of working around your brain system of that feeling of threat to then progress them back to 90 degrees. I'm not saying you'll get them back to 90 every time, but if you can slowly start to work towards that end range and then load them a little bit with an isometric at end range, it will kind of get their body used to that position. So overhead throwers, any kind of athletes like that, if they're hesitant in that position, I'll do that a lot of times.
To jump in on your question there, Dan, I'll let Eric read it here. So with dyskinesia, with the isometrics, the thing about the isometric is there's no movement obviously there too. So they may have dyskinesia through a certain range of motion or a certain elevation point at their arm, but a lot of times you can find ranges that, you know, the dyskinesia is not, you know, too significant, or, you know, sometimes too, you know, say this athlete's been, you know, this is just an acute flare-up that they've had, but they've never really had symptoms in a, you know, never had a history of symptoms. Sometimes you can make a bigger deal out of the dyskinesia than what may actually be there. You know, if this athlete's never had symptoms or injury history before, but now is just kind of in an acute tendinopathy scenario, don't get too caught up in the dyskinesia. That may be something longer term that you're looking at addressing, but focus on the acute tendinopathy and you know, what's at hand, and address the tendon and the health of the tendon first. And then as they start feeling better, then you can start getting into more dyskinesia. But with the isometrics, because you're not going through large ranges of motion, you're just kind of holding a position. A lot of times it works actual motor control in that position. You may have to play around with your different cues to try to get them positioned properly, so that there isn't as much scapular winging or dyskinesia happening at that time. With the isometrics just not movement being involved, you generally don't have to worry about that too much. I don't know if you got an opinion on that, Eric.
Yeah, no, I would agree. I think sometimes if you have somebody, if you're actually working on dyskinesia, if you can take them to a range and then have them in a proper position and then manipulate the load. So you give an isometric and they're in a proper position, it may start to, like you said, re-ingrain in their mind and their motor pattern, proper position of that scapula, proper position of the glenohumeral joint. Yeah, I would agree.
Yeah.
If you get too many components moving at one time is when things go awry. So reduce the component of movement, isolate the component of loading, and then see if you can get a change there.
Yeah, there's a lot of degrees of complexity that you could go into this. The actual just loading of the tendon is just one potential scenario that's going on. With dyskinesia, there's a lot more complexity that's involved in addressing that type of scenario. So with that, you also have to kind of consider the rib cage that the scapula sits on, and how that positioning of the rib cage could be affecting the position of the scapula, which then affects the glenohumeral position too. So there's a range of how complex you get with someone. So say that the dyskinesia is what you're looking to address. There may be some lower level activities that address kind of T-spine rib cage that you can work on simultaneously while you start loading the tendon as well too through some of these isometric phases. And then sometimes if you have an athlete who is understanding all these concepts that you're throwing at them, you can start combining it too. So then that's when the real money is made, is if you can put them, say, in that 90-90 position there, get an isometric contraction, but then also work like a breathing component or a T-spine rotation component to it to work on the dyskinesia simultaneously with the isometric contraction. That's a game changer, but a lot of times you're not able to start there with somebody. A lot of times you just got to work a lower level activity with both and then kind of figure out a way to mesh them together.
Taking us down the rabbit hole, I like it.
Yeah, it's same thing, kind of like the other one that I wanted to talk a little bit about, and we had a question from Eric from the on the Facebook group in regards to kind of similar to with the knee and Achilles, just how loading in different positions of the knee. So say with like patellofemoral pain patients, there could be a tendinopathy scenario going on at the same time as there's a loading pressure issue that's happening to the patellofemoral complex as well, which is, you know, ankle, foot, and hip implicated there. And so sometimes, and that's where, again, it's going down the rabbit hole a little bit, but how someone manipulates pressure and torque is very meaningful too, as far as how much pressure or how much stress is being placed on the tendon. So say with someone who is squatting, you know, the common example for someone with patellofemoral is everything kind of collapses into that valgus scenario. Foot pronates, knee goes into valgus, hip goes into excessive internal rotation. There's a particular stress pattern that is now being worn upon the tendon. And oftentimes, if you can use other muscle groups to take some away from their tendencies and to have them put pressure into other areas, then that takes some of the stress off the tendon, and then you can start actually loading them a little bit heavier or more aggressively with an isometric, eccentric, whatever your choice of exercise intervention may be. Yeah, so Dan, how does someone visualize torque? The knee is probably the easiest example for this. So take someone who, if you're laying them flat on the table, and you just kind of look at where the patella rests statically, and you look at the femur and the tibia. So if you put your hand and kind of put it on the outer border of the patella, and then you put your other hand on the tibial tuberosity and kind of see where it bisects the mid of patella. A lot of times you'll see kind of the patella, I'm exaggerating it, but the patella being internally rotated or internally oriented as compared or relative to the tibia. And that, again, just from someone's tendency wanting to kind of pronate, valgus collapse at the femur, just different things like that. You're seeing someone's tendency. Now, how you shift them away from their tendency is if they feel pressure through their whole foot, and you really want to kind of emphasize kind of the heel and then the big toe to kind of keep that tibial internal rotation relative as you now start creating external rotation at the hip to kind of push that patella a little bit more into an externally oriented position, which then again from your static assessment that you look at, that tendency is what you have in mind, and now actively as you watch them, you're trying to shift them away from their tendency and put pressure in other areas. So that tibia being externally rotated relative to the patella on a static assessment laying on the table, when you go to move them actively, if you keep pressure through the heel and big toe, that biases the tibia into a little bit of internal rotation. Then you have them externally rotate their femur and contract the glute. That pushes it orients things differently, so it pushes the patella a little bit more laterally, if that makes sense.
Greg, I'm not sure if this is what you're going for. If we're talking specifically for squatting, obviously you need the big thing is the 3 points of contact. You need the heel, you need the first met head, and then you need basically, if you look at like the 5th met, you need those 3 in contact with the floor. From there, I would say one of the best verbal cues that you can give, and some people don't like this, I feel like I like it. If you imagine screwing both feet into the floor, if you contract your glutes, your legs are going to naturally externally rotate. That will externally rotate the femur in relation to the tibia, and then it essentially drives the knees out. So a lot of times, and this isn't, maybe some other people have better cues, but a lot of times I will give screw both feet into the floor. It causes natural external rotation and activation of the glutes, and then the knees will hopefully track in line with that. So I don't know if that's kind of what you're going for with the torque.
Yeah. And the external cues, the analogies, they work well for some. Others, you have to kind of tell them to just, feel your heel, feel your big toe. And then as you squat down, they may notice they lose pressure there, but bringing their attention to it is the first step to feeling pressure. So feeling pressure, the heel, big toe, and then whatever cue helps them maximize that. So the screwing aspect may help them feel more pressure through those points of contact. You may also have to put your hands on them too, and just take the foot and bias them into almost an excessive amount of pronation, just so they can kind of feel what that pressure is like. And then you, as inevitably as they kind of externally rotate their femur, they're going to want to start supinating a little bit with the foot if you go into an extreme amount of external rotation. So just tell them to kind of maintain as much pressure as you can through the foot without losing contact, because you can go too far into these extremes too, and you can create so much external rotation torque that you now start supinating so much and you lose that contact point and you lose that pressure point. So making sure they understand where the pressure should be, and then manipulating your cues and how you coach them from there is going to be very client dependent.
I'm going to bring this back real quick to isometrics, since that's kind of what we're discussing. If you look at a squat pattern, or if you look at a lateral step down, and if you're talking about somebody that has patellar tendinopathy, quadriceps tendinopathy, patellofemoral pain, and you want to utilize isometrics, have them go to where they find some technical breakdown in their form, and at that point, place them in proper position, and then have them do an isometric hold there. So you're taking away that consistent quick movement component of a full squat. Let's say that typically with a step down, somebody breaks down when their foot is down 3 inches on the step. Put them there, put them in proper position, and have them hold for 20 seconds and go through several sets of that. So where are they mechanically breaking down? Put them proper, and then have them do isometrics there. 1, it'll load the tendon, which you're looking for. 2, it re-ingrains a better motor pattern in their mind.
Yeah, we were talking a little bit before the chat started. This is actually a great place where you could utilize like eccentric isometrics. So if we're talking about that squat again, or the lateral tap down exercise, going really slow on the eccentric helps them learn that movement. Sometimes when people are emphasizing eccentrics, they're emphasizing the actual tempo so much, as opposed to, you could be really bringing someone's awareness to their form during an eccentric and just tell them to go really, really slow through the eccentric and have them be a little bit more aware of their motor control during that eccentric portion. So just having them slow it down and bring their focus and attention to how they're doing it. A lot of times that right there is your 3-second, 4-second lowering is just they're being conscientious of the activity. And then you could, like Eric said, have them stop right at that point where their form breaks down, and then, you know, maybe giving them a little bit of support there so they can actually perform it competently, and then spend some time in that position.
Yeah, I would agree. I think that's most common with lower extremity stuff. Sometimes upper, but a lot with the lower squat patterns, step down patterns, things like that.
Yeah. Yeah, we got about 10 more minutes here. So Dan, if you got any other questions, feel free to let us know. The other thing that I kind of want to talk a little bit about too is, we talked about pressure and torque. Keep in mind that pressure and torque are sensations, and sensation can alter pain, which is, I don't really know if this is necessarily proven, but a lot of the research seems to be kind of moving this direction, is that the isometric contraction and the contraction of the muscle may be what the analgesic is that the fact that you're contracting a muscle, and if you feel it contracting, you feel that pressure working, it's different than a painful sensation. And by changing the perception or changing the sensation, you can potentially change the painful scenario, which pressure and torque that you create with an exercise can potentially do the same thing too, which is why you may get immediate changes in the level of pain that someone is in. It may not remove it completely, but it changes it from being painful, pinpoint, point tenderness, to more of just kind of a global pressure sensation, which now is trainable.
Yeah, with the isometric being a lot less provocative, there's no movement. So yeah, and then we don't know exactly what happens with it. Just same as all of our manual techniques, they don't know exactly why it reduces pain. But that loading, if it does something with the cortex, it then sends some like inhibitory pain signaling down. But they're using it a lot, obviously. Like anything else, you can use it for multiple reasons. The isometrics and analgesic effect is definitely a big one.
Yeah. And you know, compression's kind of that one's hit or miss as far as what the research wants to tell you, whether it's useful or not useful. But you know, some people love the pressure of a brace or some type of compression garment on them too. And again, that's a sensation that potentially is altering their perception of pain at a particular point in time. And in my opinion, if you can get them utilizing some type of active component, active pressure, it's better than using some type of compression brace or something like that, because it's now active. It's bringing control to the situation. If they like the feeling for it, you know, you're going to have athletes who like the feeling and feel it helps them out, which is fine. But, you know, a lot of times if we can bring their understanding to how they can actively control the situation, then it brings to a little bit more compliance of what they can do at home at their own time to help out with the situation too. When you say, Dan, when you say, are they cooperative with physios, are you talking about the athletes or the physician? Okay. I think once they understand how it can help them, then they are. If they don't understand what you're trying to accomplish, then they're not going to put forth their best effort, especially if you don't have a prior relationship with them. So a lot of times, and it can be a struggle first too, when you're trying to get very, very particular of how someone applies force into the ground or pressure through like we were talking about with the squat analogy. It can be tough to get the buy-in immediately, but sometimes you just got to kind of set the context a little bit before you give all these cues, kind of tell them what you're trying to do, what you're trying to accomplish. Then they'll put a little bit more effort into the actual task itself. And then if they notice the change in the pain, then all of a sudden you got them immediately as far as buy-in goes. But pre-framing things a little bit beforehand it's how you sell it is a big part of it. Yeah, that's definitely a big component there. I don't know what you do, Eric. I'm assuming you kind of do something similar there when you got someone.
Yeah, are you talking about like as far as metrics, like selling it to like, the patient then?
That's one component, selling the, how isometrics are going to be beneficial to them. But then a lot of times, like if you're getting very, very specific in how you do an exercise, and say someone's not, they just play basketball, they don't necessarily know what a good squat is. They may not necessarily know what you're trying to get across with all these different type of cues. So there's two components there of getting the buy-in of how isometrics can help them, but then also getting the buy-in of how performing it in a particular fashion is going to help them out too. So I guess that's how you frame that's a little bit different in both contexts, but it's a conversation that you got to talk about with them.
As far as it relates, so let's say you have a basketball player. There's no basketball player that doesn't want to jump higher. So as far as talking to the patient, I would say if your knees are in this position, it will activate or it will make your glutes, or I would say it'll make your hips work harder and strengthen more, which is then going to relate to you jumping higher. Honestly, most athletes don't really care as much about like injury prevention, stuff like that. They want performance. So I try to figure out a way, even though I may be going at it from a rehab standpoint, how does it relate to performance for that athlete?
Right.
So this, yeah, I'm doing it for one reason, but it's also secondary for another, if you follow me there.
Right. You can also use the analogy of like energy leaks. So they know in order to jump higher, you got to put force into the ground. And, if you could say, if your knees collapsing in, or if you're not creating pressure in this way, you're going to lose some of that energy. You're going to leak some energy, and you're not going to be able to produce as much force to jump as high. Something like that, that will at least perk their ears up a little bit and get them to start listening to you and try something. And then if it helps their pain and they notice that type of change, then all of a sudden you definitely got them at that point in time. Okay. Well, Dan, I just wanted to thank you for coming on here. Appreciate all the questions and kind of stimulating the conversation. Look forward to having you back on to some of these calls. Where are you located at, just out of curiosity?
I think you said Brooklyn.
Oh, that's right. You did put that. Yep. Cool. So same time zone. Yeah. And we're kind of working on getting some other people from other time zones. Is a little bit more difficult. The lunch period makes it easier. But yeah, if anybody else has questions they want to submit ahead of time too, we can definitely get on to this. And as we get more and more people joining the conversation, we'll probably start end up going longer. So it may turn into other time zones, lunch periods as well too. But yeah. Thanks, Dan. Appreciate that. You have a nice rest of your day, all right? Cool. See you. Thanks, Eric. Bye.